Hey, it's Ricky J coming at you live on a recording from the past.
That last battle at Hadrian's Wall was so epic, so frothy. Little kids hugging all, no, I don't want to go to the wall. That luxurious cape, so much going on. Nephrotic syndrome is characterized by marked proteinuria, greater than 3.5 grams a day due to underlying GBM alterations, as well as podocyte damage and fusion. The biggest difference between nephrotic and nephritic syndrome is the presence of significant inflammation. Nephritic glomerulopathies usually involve immune complex deposition with an exuberant inflammatory infiltrate and hypertrophy of mesangial cells. There's significantly less proteinuria, and because of the inflammatory damage, both red blood cell and white blood cell casts are found in the urine sediment. Yep, hematuria is much more prominent in nephritic syndromes. And speaking of, no greater amount of blood has been spilled over a single wall than the Great Wall of China. Only a few years before William Wallace was rallying his troops against the English, far to the east, another battle was raging. The Mongols were rapidly moving southward in their quest to conquer the territory of the Jin dynasty. And in 1213, Genghis Khan and his armies had finally reached the Great Wall. Next, an invasion right into the heart of China. All right, the layout of the battle is pretty similar to last time, with the wall representing the glomerular basement membrane. So let's get our bearings. There are 3 layers we have to cross before we can get from the lumen of the glomerular capillaries all the way to the inside of Bowman's capsule, or Bowman's space. This time the glomerular capillaries are rings of Mongols getting cozy around the fire, planning their next move. The field surrounding the capillaries, that's the mesangium, the cells providing structural support to the glomerulus. And the glomerular basement membrane, it's hard to miss this time, because you can see it from frickin' space. It's the Great Wall of China. Just on the other side of the wall, the ever-watchful podocyte foot soldiers. These guys have foot processes adhered to the basement membrane. Between the foot processes are filtration slits, which provide another layer of selective permeability. So, yeah, they're watching you. And beyond the wall, China, where the river flows. Or, as we call it here at Sketchy, Bowman's space, where the urine forms. All right, back to the capillaries. Focus again on the fire smoldering away inside each camp. The underlying theme in nephritic syndrome is inflammation. So, what's triggering all this inflammation anyway? Most of the diseases associated with nephritic syndrome that we'll meet out on the battlefield today cause immune complex deposition. Immune complexes form when immunoglobulins bind to an antigen. And in this scene, they'll be represented by a mace. Kinda reminiscent of a bunch of little antibodies coating an antigen, right? These antigen-antibody complexes then float around in the circulation for a while, before reaching the kidney. That's when they get stuck, depositing somewhere in the glomerulus. Using electron microscopy, you can actually see where these immune complexes ended up. Usually, the immune complex will slip through the capillary wall, but then immediately get stuck in either the subendothelial or the mesangial layer. The mesangium, remember, is the region of cells right outside the capillaries, while subendothelial means right between the capillary endothelium and the basement membrane. So in this scene, that means between this soldier here and the Great Wall. Thus, he's wearing the mace on his back. I also want you to pay attention to the color of the immune deposit mace. It's green and has kind of a granular pattern. In this sketch, bright green means you're looking through a fluorescent scope to look for glowy immune complexes. Usually when you look at the entire glomerulus on a slide, these glowy complexes form a so-called granular pattern throughout. It's a buzzword they love to throw in that question stem. When they describe something as granular under fluorescence microscopy, think immune complex deposition. Immune complexes trigger local activation of the complement cascade. At Sketchy, the complement system is represented by, well, a complement. See these 2 Mongols here, complimenting each other on last night's invasion? You were great during that last invasion, Craig. No, really? Yeah, just an all-around solid effort out there. Aw, stop it. Specifically, C3 is cleaved into C3a and C3b. This is why C3 levels in the blood will be decreased. Additionally, C5 is cleaved into C5a and C5b, and C5a is chemotactic to neutrophils. So just look for that C5 complementary high five, and neutrophils won't be far behind. Neutrophils are a key inflammatory infiltrate that mediates the damage to glomerular capillary walls. Just take a look. We've got a capillary endothelial cell down already, carried off by an infiltrate of neutrophil first responders. Continuing damage to glomerular capillaries means we're going to see blood in the urine and a reduction in the glomerular filtration rate, or GFR. These are the hallmark findings in nephritic syndrome: extra leaky glomerular capillaries and acute kidney dysfunction. And as was the case with nephrotic syndrome, regardless of the specific underlying pathology, nephritic syndrome is defined clinically. Nephritic syndrome is characterized by hematuria, as depicted by the trickle of blood running down the first responder's thigh there.
Probably should put some pressure on that.
As a result of direct damage to the capillary walls, glomerular basement membrane, and podocytes, red blood cells pass directly into the urine. This may manifest as gross hematuria, often described as tea or cola-colored urine, or it can present as microscopic hematuria. In either case, when you look at the urine under the microscope, not only will you see red blood cells floating around, you should also identify dysmorphic red blood cells and red blood cell casts. Dysmorphic red blood cells are represented by this Mongol warrior, who looks a little bent out of shape, to say the least. The cells are misshapen, lysed, or dysmorphic due to free radical or oxidative damage encountered in the inflamed glomerulus. Red blood cell casts form when the cells clump together, filling the lumen of the renal tubule. These clumps pop out into the urine as cylindrical casts, kind of like this collection of helmets floating down the river, foreboding of some kind of traumatic event back at the capillary camps. These two features, dysmorphic red blood cells and red blood cell casts, are your go-to markers for glomerular bleeding. If the bleeding is coming from somewhere further down the urinary tract, maybe a stone in the ureter or cystitis, you'll likely see red blood cells only. Remember, this is nephritic syndrome we're talking about here, and that means glomerular inflammation. So white blood cells and white blood cell casts may find their way into the urine too. Nephritic syndrome is also characterized by a reduction in GFR, which shows up as oliguria and azotemia. Azotemia is just another word for BUN and creatinine on the rise, and oliguria means a urine output of less than 400 milliliters in 24 hours. So take a look. We've got young Genghis here, getting prepared for battle with the help of his mom. "No, you're gonna do great today, little Genghis." "Who's my little Genghis?" She even brought him his favorite pre-invasion snack, our recurring BUN hamburger. Also, that little trickle coming out of the cup there should remind you of the associated oliguria. These are signs of AKI. Decreased GFR leads to fluid retention as well. Add a little salt retention on top of that due to augmented renin release, and get ready for some hypertension. Just look at that high-pressure steam.
Mom, you're embarrassing me in front of all my warrior friends.
Fluid and salt retention can also cause edema, though this usually isn't the same kind of generalized edema we saw with nephrotic syndrome, when we were dumping albumin into the urine. In nephritic syndrome, edema is usually mild or periorbital. Just think of little Genghis's periorbital puffiness as his mom squishes his little cheeks. "Yes, you are. Yes, you are. Who's my little con?" All right, for the last important finding, let's head back to the urine. Glomerular inflammation usually involves basement membrane and podocyte injury as well. And when you lose that negatively charged barrier, say hello to proteinuria. Most patients will excrete only moderate amounts of protein, far below the 3.5 grams per day seen in patients with nephrotic syndrome. So just a couple chicken legs this time, not the entire meat card. And now, the moment of truth. As the battle unfolds, we'll quickly run through a few of the more common underlying pathologies that cause nephritic syndrome. For each pathology, we're going to focus on 4 things: where in the glomerulus the immune complex deposits, what the most likely causes are, what it looks like on microscopy, and if it responds to steroids. The most common nephritic syndrome is IgA nephropathy, also known as Berger disease. It affects children and young adults, and it's represented here by this young warrior in training. See those practice dummies? They're meant to evoke an image of IgA molecules deposited in the mesangium. Remember, the mesangium is the supportive field around the capillaries. So how does IgA get here in the first place? Recall that IgA is normally secreted at mucous membranes, especially during a mucosal infection. Ah, look at these two fledgling warriors. Too sick to train. That must have been one bad burger. In some genetically susceptible individuals, when the mucosa of the respiratory or GI tract is exposed to an antigen, it may lead to abnormally increased IgA synthesis. Some of it may be abnormally glycosylated as well. Both IgA and IgA-containing immune complexes eventually find their way to the glomerulus and get stuck in the mesangium, where they activate complement. The classic board scenario is a young kid who recently had a cold or gastroenteritis, but then has hematuria 1 or 2 days later. The hematuria can be microscopic or gross and lasts for several days. The weird thing is that about every 2 months, the hematuria will return. This periodic hematuria is represented by these periodic little red puddles left behind by the sick Mongolian children. Most patients will maintain normal renal function for years, though 25 to 50% of cases will progress to chronic renal failure. IgA nephropathy is also highly associated with Hennig-Schonlin purpura, an IgA vasculitis syndrome characterized by rash, abdominal pain, arthritis, and nephritis. The characteristic lower extremity palpable purpura are illustrated by our Hennig-Schonlin shoe shiner over here.